Okay, so let's get cracking. So we're going to look at mainly paediatric surgical cases, because this is what a lot of questions which focus specifically on paediatrics will ask about. A lot of the more medical side of the presentations that children can have will be covered already in your adult modules, such like your GI and whatnot, because kids can still get IBD, celiac, which is an important one in kids, because obviously it can affect their growth and development. And other abdominal conditions, appendicitis, things like that. You will have covered those in ones already. So we're going to focus on ones that you won't have really looked at in adults as much. Important caveat for that though, is for any condition, whether you've covered it in a more adult orientated module or in a pediatric module, is you want to think specifically about, particularly for the abdomen and the digestive system, how is it affecting their feeding? How is it affecting how they're growing, how they're developing, how they're flourishing into a child and a young person? So I don't know what's happening with your guys' OSCEs this year or whatnot, but when you're taking, if you're taking histories from pediatric patients, remember to ask specifically about how they're feeding, how they're growing, and how they're developing, and how the conditions are affecting that. Okay, so that being said, we are going to focus mainly on surgical cases in a second, but they can also ask some questions related to problems with feeding. And there's two big problems with feeding that they can have. They can be allergic or hypersensitive to certain foods, and they can have intolerances to certain foods. So we'll look at allergies first. And an allergy in this case can be defined as a reproducible immunological reaction to the same exposure. So they eat the same foods, they get the same reaction each time, and it's immune mediated. It can be IgE mediated, and if it is, it comes on really quickly, and if they present with the typical symptoms, swelling, rash, the typical anaphylactic allergic symptoms. It can also be non-IgE mediated, and it comes on over a longer period of time. They won't present with the typical allergic symptoms, more typically GI symptoms. Intolerances, far more common than allergies, and there's lots of different causes for this. It might be due to like enzyme deficiencies, they might have eaten something dodgy, they might have a developmental abnormality which needs investigating. So there's two, when I remember going over exams and doing mocks and whatnot, there was a couple of particular things they liked asking about for feeding difficulties and things that they like to focus on there. So the first one that I remember quite vividly is they liked asking about cow's milk protein allergies. So we'll focus on that. So in your question, it might talk about that the child presenting might be in the age group 2 to 8 weeks old. It can come on after they either drink normal cow's milk or after taking their mum's milk. If mum is also drinking cow's milk, she can pass it on in her breast milk. She can pass on the antigens through her breast milk to the baby and cause that allergic reaction again. So again, before, it can either be IgE mediated or it can be non-IgE mediated. And the time of onset can give a clue as to which way it is mediated, although that's not really important clinically right now when you're diagnosing the child. They might present with some blood-tinged stool, which it might be an important factor in the question, the stem of the question which you're being asked. And they might also have some of the dermatological manifestations of allergy as well. To treat a cow's milk protein allergy, you want to completely cut it out of their diet. So that means that they can't drink any milk. They need to have special, any formula milk that they're on. You need to check that that's not got any cow's milk in it. And also mum can't have any cow's milk if she's breastfeeding as well. Once they're about 9 months old, you can then try reintroducing it, as they might have grown out of it by then. Slowly reintroduce it. see how they do. If they need to wait a bit longer, that's fine. Try reintroducing it at a later date after that. An example of intolerance, I remember a couple of questions on lactose intolerance, which again will emerge in kids. Adults can have it as well, but you might start seeing it when someone is still a child. So you've got different causes which may lead to lactose intolerance. They might either be deficient in the enzyme used to break down lactose, or they might have problems with malabsorption. So again, going back to celiac, that important one, might have problems with absorbing stuff. Your GI tract might be damaged. Gastroenteritis might do the same thing. Developmental problems with the GI tract can all lead to problems absorbing that lactose and breaking it down. So these children can present with loose stools, abdominal bloating, abdominal pain, gas, and to treat lactose intolerance, you either give them that lactase so they can break it down, or you limit their intake or stop their intake of lactose. With an intolerance, it's often more dose dependent. So the more, let's use example of lactose, the more lactose you give them, the worse their symptoms will be. Whereas with an allergy or a hypersensitivity, it might just be a tiny weeny bit that they have and it'll set them off into full-blown allergy. Okay, so that's the feeding bit out the way. So let's go on to a couple more surgical bits and bobs. So the first one that we'll look at is pyloric stenosis, which is quite a classic one. So pyloric stenosis is, as the name suggests, the pylorus at the bottom of the stomach, the outlet of the stomach, the muscle around there is overgrown. This leads to a narrowing or a stenosis of the outlet of the stomach to the point where not much, or if anything, will be able to pass out of the stomach. It's more common in male kids and also more common in those who have a family history of pyloric stenosis. So these kids might present with projectile vomiting. It's important to ask, if taking the history, or to look in the stem of the question, inquire about the vomiting. Is it proper projectile? Is it whizzing through the air? Or is it just the dribbling that some babies might have if they've had a bit too much milk? That's an important thing to rule out in the question. It's typically non-bilious, and depending how much they are vomiting and retching, they might have some hematemesis mixed in with the vomit as well. Typically they present tired, hungry, but with failure to thrive, because they're really hungry because they're wanting to eat all this stuff, but they're not able to absorb it because it's not passing through into the bowel where it would be absorbed. So they're not getting any of the good stuff that they need to grow, to thrive, to get their energy. And they're constipated because not much is passing down through the bowel to come out as poo. It's all coming back up as sick, okay? On examination, again, similar. They might be thin, they might be hungry, they might be dehydrated because it's not passing into the bowel for them to absorb the stuff that they need. Here, this is a clue towards the fact that on examination you might feel the classic olive in the upper abdomen, which is, you can actually palpate through the abdominal wall the hypertrophied pylorus, which they describe as an olive. I've not felt one myself, so I don't know how olivey it feels. But so investigations wise, so sometimes, you know, if the baby's uncomfortable, if they're feeling sick, the abdomen might be really tense. They might not just like you pushing all over their tummy. So what you can do is you can give them a dextrose test feed, and by giving that, it relaxes the abdominal wall, so it lets you feel a bit more deeper, and see if you really can feel that olive in the right upper quadrant or not. Typically, so this is a good exam question that you might want to think about. So on a blood gas, it would be a metabolic acidosis with hypochloremia and a hypokalemia, because they're losing their electrolytes with all the vomit that they're producing. So that's a good point to write down. You might, if your clinical suspicion is still, I'm not sure if I'm feeling that olive or not, you can do an ultrasound abdomen, and they look at 3 things on the ultrasound abdomen. They want to see how thick is that pylorus, how long is that pylorus, and how much fluid is able to pass through that pylorus. And if you need to, again, you can move on to contrast studies, where I think, what's the name of the, let's have a think, the string sign. So this is an ultrasound, which I have on the screen. I don't know if you can see my mouse, but the ultrasound here shows the thickened muscle and the lengthened muscle. And I hope you can appreciate the thinning of the gastric outlet there. And there's something called a string sign, which on contrast studies, you might see a very thin, stringy line of contrast going through the gastric outlet, which shows how thin and narrowed the outlet of the stomach is. So treatments-wise, we've just said they're losing all this fluid, they're losing all of these electrolytes. So the first thing we want to do is replace it. That's what we can do as juniors, start replacing those things that they need. And then you can move on to surgery, get your seniors involved. And the procedure that they perform is called a pylomyomectomy, I believe, when they reduce the thickening of the muscle and widen back up the gastric outlet so that it can function normally. Okay, so the next classic PEDS case is intussusception. So intussusception is the telescoping or invagination of a proximal bowel segment into a distal bowel segment. The most common place where this happens is the end of the small bowel going into the start of the large bowel, the terminal ileum into the cecum. It can lead to, because you've got the invagination, you've got the pinch points about where it's rolling over each other, and those pinch points can lead to, first of all, venous congestion, and once that starts happening, you get more swelling, more pressure builds up, and eventually the arteries will get blocked as well. This can lead to some tissue damage, some tissue hypoxia, which can lead to severe abdominal pain in a child. Classically, in a history, they'll be screaming, inconsolable, drawing the legs up towards their abdomen, and then the pain will go away. And then it'll come back again, and then it'll go away again. This is used to remind us of the classic term red currant jelly stool, or cranberry jam stool, or I've not seen it myself, but that's the classic textbook characteristic of a child with intussusception stool. Again, on examination, this is, again, we're interrupting their feeding, aren't we? Whenever they're feeding, this is more likely to happen. So they're not absorbing as much as they want, they're not feeding well, so they might be dehydrated, might be tired. And again, you want to feel their abdomen. Again, the right upper quadrant, where we'd find the olive in pyloric stenosis. We're going to look for a sausage this time. I've not felt one myself. I'm not sure how big they are in the abdomen, but again, that's a classic textbook term to latch onto if you read it in a question. So bloods here, they might show signs of inflammation, because obviously when you have hypoxic damage to tissues, you get some inflammatory changes. So you might see a raised CRP, you might see some raised white cells, and we might see some electrolytes disturbed as well, because again, they're not taking in as much foods as they want, so they're not taking as much electrolytes as they want, so the electrolytes are going to get deranged on the bloods. Ultrasound, so this is a good ultrasound to show you. So if we look, again, I'm not sure if you can see my mouse, but if you can, and we look at the image on the right, that's looking head on at the bowel, and I hope you can appreciate the target sign of the proximal section invaginating within, telescoping within the larger section of bowel. So that illustrates it really well. And then the image on the left shows, it's a bit harder to appreciate, but it shows it looking side on, like a sagittal view of the bowel, and it invaginating in that way. So again, treatment, what can we do? So we can give them fluids, we can replace their electrolytes, okay? They might need IV antibiotics, depending on the damage that has occurred in the bowel. And once seniors are involved, first of all, they will try a pneumatic reduction, so an air enema, so they will pass some sort of pneumatic tube into first of all into the rectum to try and reduce that intussusception and inflate the bowel back to normal again. If that doesn't work after a few tries, they might take the child for urgent laparotomy to do surgery and open up that bowel and fix it. It might be interesting to note that intussusception can be a feature of Henoch-Schönlein purpura or IgA vasculitis. So children with IgA vasculitis are more likely to have intussusception than other children because the vasculitic changes, the inflammation affects the GI tract, and where that inflammatory changes and swelling and damage occurs can act as a pinch point for the bowel to invaginate within on itself. So I've seen a child with HSP who has presented with intussusception as their main presenting feature. Okay, so next one. So gastroschisis, however you want to say it. So this is quite an obvious diagnosis in newborn children, and before they're even born, we can often identify this. And what it is as a result of is the abdominal wall fails to properly close during the development of the fetus, and that means that some of the bowel can herniate out of the abdominal wall and outside of the body of the child. Typically, it's to the right of the midline, and the important thing to note in the difference between this and the Exomphalos, which we'll move on to in a second, is that gastroschisis is not covered in peritoneum. It's just the bare bowel that is herniated out of the abdomen. It is usually detectable on a fetal anomaly scan, which we can see here. I hope you can see this with the baby near the bottom, and then this fluffy bit around its abdomen, which is some of its bowel that's protruding out as a gastroschisis. That's how it may look on a picture. So to treat this, so there's I'm not entirely sure why this is, but there is an increased risk of intrauterine death, and so obstetricians and paediatricians may decide to deliver the baby earlier than you may otherwise want to deliver them. Once they are delivered, you'll want to, again, fluids, antibiotics if needed, and you want to use an NG tube, pass an NG tube, drain that stomach, get rid of it, make as much space in the abdomen as possible so that you can start thinking about reducing the bowel back into the abdomen. And they reduce that bowel back into the abdomen by either using surgery, depending on the size, or often they've, I'm not sure if anybody's seen one of these in Alder Hey, but using a silo. So it's like a cling film cylinder thing, which the baby lies on their backs, and the bowel is hung in this cling film cylinder above them, and it uses gravity to gradually, with the help of clinicians every now and again, to help it move back into the abdomen, and it will gradually drop back in as the baby grows and as space is available. You feed these children with TPN to start with because the bowel has developed outside of the abdomen. It hasn't developed in the normal conditions it typically wants to. So it's not developed as normal. It doesn't work as normal. It doesn't absorb stuff as normal. So you want to start with TPN, and then as the bowel's getting more used to being in the abdomen, making changes and adapting to absorbing food, you gradually increase their oral feed slowly. It's important to note that I've read somewhere that because these babies need TPN, gastroschisis can be fatal in developing countries where TPN might not be available. So it's an important thing that these babies need is TPN. Because of you're obviously putting more stuff back into their abdomen that the baby's not used to having in there, the intra-abdominal pressure will increase. That will make it more difficult for their breathing, which they're not used to, and they're at slightly increased risk of needing to go onto a ventilator for some amount of time. Okay, so Exomphalos. So we've just mentioned this Pretty similar. I always got it mixed up between gastroschisis and exomphalos when I was revising for this. But an exomphalos is an umbilical herniation. And the thing to remember between the two is this one is covered in membranes, 2 layers. You've got the peritoneum and you've got the amnion, which is covering it. And because this one is an umbilical herniation, obviously the umbilicus is typically in the midline. So an exomphalos is in the midline, unlike a gastroschisis. Exomphalos is more commonly associated with other genetic abnormalities, unlike gastroschisis, which is more just an isolated, spontaneous finding without a genetic history. This one is more likely to be associated with things. I think Beckwith-Wiedemann syndrome is one of these. It's also commonly associated with syndromes affecting congenital cardiac defects. Yeah, again, it can be picked up on ultrasound. And after birth, we've just said it's associated with those other possible genetic defects, other syndromes. So you want to try and rule out any ones with them. So you want to do an echo to see how their heart is. Is there anything developmentally wrong with that? Is there anything developmentally wrong with their kidneys? You might want to do a karyotype for chromosomal syndromes. Treatment-wise, it depends on the size of the defect. If it's small, like a tiny weeny umbilical herniation, they might fix it really soon after birth by reducing that herniation and suturing up the umbilicus, sorting out the hernia. If it's, excuse me, if it's a larger defect, often they leave it for quite a while to let the child grow. Sometimes they can leave it for up to a couple of years, depending how severe it is. And this allows the bowel to keratinize, to develop properly, and to get a bit more able to, again, absorb stuff. It doesn't need TPN as badly as gastroschisis does. These children are able to typically absorb food through the gastrointestinal tract and thrive as best they can. Again, they might need a ventilator due to we're putting more volume back into their abdomen, and they might need TPN, but it's not as much as gastroschisis, which we mentioned before. Okay, so next one. We're not covering too much because I feel that we don't need to do so much overwhelming stuff. We're just going to cover the big, commonly asked paediatric surgical cases. So we've not got too much left to go now. So next one is Hirschprung's disease, which is, I'm sure you all know, it's a congenital lack of nerve plexi, nerves in the GI tract. And it always begins at the distal end, at the anal sphincter, and extends back a variable length. The longer it goes on for, the more rare it is. So the more common ones affect, excuse me, affect the proximal length. Okay, 90% of these kids present as within the 48 hours of being born, with being unable to pass meconium, to pass their first stool, which they normally do within the first 48 hours. If it hasn't been picked up for whatever reason in those, or they're not thought about it for whatever reason within those first 48 hours of not passing stool, but you might see progressive abdominal distension, you might see vomiting, because obviously not much is coming out this end, so there's got to be some coming out of this end. And if someone thinks to do a PR examination on these babies, they might all of a sudden release this pressure and they might get, we've talked about projectile vomiting in pyloric stenosis. This will be some explosive diarrhea coming out the other end in Hirschprung's disease because you release that pressure. So a lot of gas, a lot of meconium, and a lot of stool coming out. So to investigate it, the gold standard, once you've got a clinical suspicion, is think about a rectal biopsy. So we'll take a sample of the rectum, put it under a microscope slide, and see if they do have those nerve plexuses in there or not. That is the definitive diagnosis of whether they've got Hirschprung's disease or not. Before that, someone might think of doing an abdominal X-ray, which shows the affected aganglionic section without the nerves will be really thin, really shriveled. And as you're moving through the transition zone, obviously it widens, it becomes cone-shaped, and then the proximal bit, the bit that isn't affected, that still has its nerve supply, will be distended, because the stool's moving through there. It's trying to innovate, to push that stool through, but obviously the rest of the bowel isn't really responding and taking, it's all shriveled up beyond that. So it will be distended with stool gathering in there. I tried to find a good abdominal X-ray of this, but it was actually quite tricky to find a good one to show you. So I wasn't going to just put on any old distended bowel X-ray to confuse, because it wouldn't be any use for any of us, would it? So yeah, treatment-wise, first of all, we want to decompress that bowel. So we've talked about that explosive diarrhea. We've decompressed the bowel when someone's done that PR examination, but you want to keep doing that. You want to wash the bowel out. Don't let the stool and the meconium gather in there. You want to keep the bowel moving through as best you can. They can also decompress the bowel by doing a stoma, a temporary stoma, which they will eventually aim, in most kids, wherever possible, you will aim to reverse the stoma and connect resect the section of bowel which is aganglionic, and hook up the normal innervated bowel to the anus, so they can they won't have a stoma, they can pass stool normally, would be the overall aim for these kids. So something that's not actually that common, but that is mentioned in exam questions, because there's some nice things to mention about it, is Meckel's diverticulum. So I'm sure we've all heard of the rule of twos in Meckel's diverticulum. If in doubt with a question of Meckel's diverticulum and there's something with a number 2 in there, it's always a good shout, because as you can see, there's all sorts of 2s in there. Males are affected more commonly than females. Excuse me. And typically, it might include one of 2 types of mucosa. It might have some pancreatic tissue in there, it might have some gastric tissue in there. And typically, they're that small, not really bothersome, don't bother the child that much. But they can, if they do bother the child, if that pancreatic or gastric mucosa is producing some digestive enzymes or some acid which might damage or irritate the bowel, then they can present with ulceration and bleeding, because the bowel has been irritated and damaged. They can present with intussusception, as the Meckel's diverticulum can again act as that lead point, that pinch point for intussusception to occur around or near. They can present with a volvulus, because the vitelline ducts might still be there, so it might get, as the abdominal contents is moving around, it might get caught on it and it can twist around on itself and lead to a volvulus, a blockage, a twisting. And they can present with diverticulitis, because it's a diverticulum. They've got this mucosa that might be irritating thing. It might get irritated by something else, might be an infection, an inflammatory process on board. So they might present with diverticulitis as well. Definitive investigations for a Meckel scan is, for a Meckel's diverticulum, is a Meckel scan. So this is a technetium isotope uptake, which shows very nicely on radiological imaging the Meckel's diverticulum. I don't really know how commonly this is used, but that's the gold standard of investigating for when you think they might have a Meckel's diverticulum. Treatment-wise, there's some dispute as to what is the best treatment for it. With apparently the majority advocate for a laparoscopic excision, a prophylactic excision of it, in case it were to cause further problems in the future. That's not for a junior to really decide. What we want to do, think about, is treating those complications, try and think about where's that bleeding come from, what can we do about the GI bleeding, what can we do for a volvulus, what can we do if they're showing diverticulitis, signs of inflammation on blood, signs of infection. That's what we want to be thinking about. So this isn't a surgical case, but it's something that I don't know if anything's changed since I covered this in teaching when I was taught this, but I don't think mesenteric adenitis was covered much, if at all. So I thought we'd just go over that and cover it quickly. So yeah, it's a common cause of abdominal pain in typically like young children up to mid-teens. And as the name suggests, it's inflammation of lymph nodes in the mesenteric system or area. It can mimic appendicitis with the abdominal pain, because obviously with appendicitis, you start off with your central abdominal pain, which soon localizes to your lower quadrant. Typically, it's viral, but you can also have bacteria which cause it as well. And a lot of common bacteria have been associated with it, such as Campylobacter, for example. In the question, this is like, if they're going to ask you a question about it, I feel that this is how they're going to hint to you that it might be mesenteric adenitis. So they might have a preceding history of another infection. So it might be an upper respiratory tract infection, it might be a UTI, it might be a GI infection, and then a couple of days, couple of weeks later, they're going to present to you with this vague abdominal pain with possible fever, loose stools. They might have nodes which are felt elsewhere. I feel that could be a question, a hint to think, oh, let's maybe think mesenteric adenitis. So yes, so it's a clinical diagnosis based on the history and your examination, as a lot of things are in kids. If you want to investigate things, then it's to rule out more serious things. As with anything, you want to be thinking when you're seeing a patient, what do I think it is? What could it be, but it might be a bit rarer? And what do I really want to rule out? What's something really serious that I want to be super careful and make sure that I don't miss? So this is what you're doing here. You're investigating to rule out important differentials. Is it acute appendicitis? We really don't want to miss that. Is it intussusception? We can do something about that. Or is it a Meckel's? We can be aware of that, and people might want to do something about that. So yeah, so we want to look for signs of inflammation, infection. We might image to look if there is any signs of appendicitis or intussusception. To rule out other infections, you might want to do like a UTI, sputum culture, but the ship may have sailed on that infection might have passed, and this is a delayed immune response to that, okay? And it's pretty heavy to do a diagnostic laparoscopy, but if you're really, really concerned that they might have an acute appendicitis, then someone might consider doing that. Treatment-wise, just got to, conservative management, manage the symptoms, look after them, give them pain relief as they might need, keep them hydrated. Nice and simple, nothing tricky on that one. I thought I would, so that's the main cases. Please, if I'll check the chat list. I've minimized the Zoom grid thing for a second, but I'll check the chat. So please do, if you want to ask about anything else in particular, do ask about any more paediatric GI or any paediatric stuff. I'm more than happy to answer it. But I've got a couple of tips here as well to think about. In a peds history, whether it's a GI thing or a respiratory thing, anything, because with respiratory bronchiolitis can really affect your feeding. Congenital heart defects, feeding problems can be the first sign of a possible congenital heart defect. Always ask and examine for problems with feeding, with growth, with development. You'll get plenty of marks in your OSCEs asking about things like that. In the right sort of patients, obviously, teenage girls typically, still consider obstetric and gynecological causes of pain. It's okay to consider ruling out a pregnancy test, to ask questions like if they're sexually active. Think about, ectopic pregnancies. Do a pregnancy test if in doubt. That's okay. And again, we've not talked about those common things, gastroenteritis, appendicitis, because we've already talked about those in adult stuff. We've done CBLs about them. We've done lectures about them. But remember, in kids, it might be a bit more vague. It might not be, I don't know if it might be a little bit more obvious in an OSCE what they're getting at, but in real life, definitely. These presentations, so let's say appendicitis, a lot more vague in a kid than they would be in an adult. Because children find it harder to tell you about pain and to quantify it and to localize it. So yeah, be super careful, be really thorough in covering those sorts of things. In any child with temperatures, vomiting, loose stools, GI upset, always think, as was always told, could it be sepsis? Rule out sepsis, do cultures if needed, look at inflammatory markers. Yeah, and always safety net. Next year, when you're 50 years, you'll be doing a paediatric A&E experience of some sort, whether it's an Alder Hey or a DGH, unless they're changing it. But if you hopefully you'll have a paediatric A&E experience. I did mine in Alder Hey, say, and you'll find that a lot of the kids that come in are often, they're not particularly unwell. Mum and dad are just really concerned. They're not keeping their food down. They're not feeding very well lately. And you might be able to identify that they're not seriously unwell. There's nothing seriously wrong with them. The doctors might back that up. But they will always, and this is an important thing to do in your OSCE as well, safety net. If they're still concerned, if things haven't resolved in a day, however long, after trying whatever advice you've given them, come back. That's super, super important, and you'll get marked for that as well. I'll point out that when I was going revising again for this talk, and when I was revising for my finals back when I was at the same stage as you guys, I used this book, The Unofficial Guide to Paediatrics, which looks like this, which is really, really good, really quite thick, loads of paediatric stuff in it. So I could recommend that highly. And I know there's the sunflower book that everyone raves about as well. But I use this book more commonly, and I can really recommend that. So that's all I've got. Oh, let's see if we've got, is that a chat thing? There we go. Okay, so in Hirschprung's disease, if the exam question asks for the first investigation, do you put abdominal X-ray or rectal biopsy? I would say that that's quite a difficult question. I would say that the question would be asking more for a gold standard investigation, I think, and that would be the rectal biopsy. The abdominal X-ray, I don't think it's a particularly definitive investigation for Hirschprung's disease. And a child may well have an abdominal X-ray when you're still considering, so you might not know that it's Hirschprung's disease at this point. So if you're still wanting to investigate what it could be, yes, do an abdominal X-ray. If you're further down the line and thinking, oh, I think it might be Hirschprung's disease with all that they've not passed meconium, they've done, they've had that explosive diarrhea, but you're further down the line of thinking that way, then rectal biopsy is what's going to tell you, is it or is it not Hirschprung's disease. Next question. Are questions on biliary, jejunal atresia, etc. common? No. Well, from my experience, no. There might be some questions on them. It's I can't say that you're not going to get asked about it, but I don't remember getting asked a single question on those. So definitely go over it if you have the time, but don't stress about it too much. Also, maybe have a think about, you know, the tracheoesophageal fistula, esophageal atresia. I'd read about them. I'd make a couple of notes about them. I wouldn't stress about it too much. Cool. Oh, another question. So, pyloric stenosis is more commonly seen in quite a young child. Sorry, I'll read out the question if people aren't seeing the chat. What ages are pyloric stenosis and intussusception more commonly seen at? So, pyloric stenosis is often seen in a younger child. You're making me put a number on it now. I'd say months old, I would say, because that pylorus is hypertrophying, for want of a better word, and it will take a while for the gastric outlet to be properly blocked, but it will be within quite a short time frame because it will have been stenosing in utero as well, and the problem will manifest itself soon after birth. So I'd say a months-old child, weeks to months old for pyloric stenosis. Intussusception, it's a wider age range for presentation. It depends on the what might be associated with it. So that kid that I saw in Alder Hey who had HSP and then intussusception he was about 6 or 7. But younger kids can get, so when we were talking about that, you know, the kids that will draw their knees up to their chest and they're inconsolably crying, they would be younger kids, they would be infants. So there's a much wider age range for intussusception. Pyloric stenosis, is it metabolic acidosis or alkalosis? Let's double check. I don't want to tell you the wrong thing because I thought it was one thing in my talk, but let's double check and see what the book says to corroborate our answers. Give me 1 second to find it. Okay. There we go. Here we are. Okay, so it is an alkalosis, which I think, I'm sorry if I got that mixed up in my slides, but no, it's, yeah, alkalosis. The book says it, I think it's an alkalosis, so hypokalemic, metabolic alkalosis. Yeah, I think that's all the questions. I'm going to, before you go, I'm going to paste into the chat the SurveyMonkey feedback. If you could fill in the feedback, that'd be absolutely fab, guys. And please do keep sending. Oh, sorry. Oh no, I don't want to just send it to one person. I beg your pardon. Technophobe. There we go. Yeah, please do fill that in, and please do keep sending the questions. I'm sorry that I haven't been able to put in like cases and questions for us to go through this. I cobbled this together at the last minute, but I'll try and send Fraser some cases or questions that I can remember coming up, and he can send them out to you. But yeah, please, any more questions, I'll stick around for a bit, or message me via Facebook, wherever you want. I'm more than happy to chat. I hope I covered, I didn't want to overwhelm you guys. I hope I covered the important things that I think are good questions to latch on to, good clues that you might have in your questions. Because they can only ask you so much. You don't need to know loads about the treatment. So yeah, I'll stick around for a bit.